And now we are already slightly running behind schedule, and straight away we go to the next session. For this session, I'd first like to invite the chairpersons. It is a proud privilege for me to invite the first chairperson, Professor Uma Parvansoikia. She is a teacher and excellent endocrinologist, she is a great teacher. And then we have Dr. Piyush Nayak, who is a consultant and general medicine in Hanford Hospital. And third chairperson will be Dr. Vinod Priyadarshi. He is a senior consultant urologist at Mission Hospital, Durgapur. So I'd like to hand over the proceedings to the chairperson. Madam, please just take over.
A very good evening to all of you. Am I audible?
Yes, ma'am.
And I thank the organizers for giving me this opportunity to chair this session. So our first speaker in this session will be Dr. Banshi Sabu, who is well known to everyone in this audience. However, for the sake of introduction, I would say that he is a chief diabetologist and chairman of Diabetes and Hormone Clinic at Ahmedabad. He is the president of the RSSDI. He has various publications to his credit. He is an expert. He has been an expert in the RSSDI guidelines for the management of diabetes. He has been awarded the most impactful healthcare leader by World Health and Wellness Congress and many other awards. So without wasting much time, I request Dr. Banshi Sabu to first start his talk on defeating diabetes and RSSDI initiative.
Okay. Hello. Am I audible now?
Yes.
Thank you, Chairperson, for giving me this opportunity, and thanks for kind words. Thanks, Dr. Amita Vishwas, for this wonderful opportunity to give a talk on a topic which is very interesting, because this wonderful initiative which we have started with under the RSSDI, being RSSDI president, we thought of to do a program or a campaign on a defeat diabetes. So I thought, let me discuss about what exactly this defeat diabetes campaign. I'm sure all of you must have seen on social media platform. So in next 20-25 minutes, I'll be talking about this defeat diabetes campaign. You can see my slides. Slides are visible?
Yes, Bansi, your slides are visible.
Okay, thank you. So this is 100 days to reach 100 million. And that is what we thought of, that we should have a mass level campaign, a social campaign to reach more and more persons in India to know more about the diabetes. We had put a tagline of testing, tracking and treatment. So the test, track and treat, that is what under the campaign of defeat diabetes. I'll be talking about this campaign more in next 15 minutes. We know that diabetes is increasing all over the world, particularly in our country. The way it is increasing, whatever the figure which is we are getting from IDF or from World Health Organization, we actually get that figure before 5 years. So suppose whatever is projected in 2020, we have received, we were having already that number of patients already in 2015. So that sort of a projection is there in our country, and that sort of patients which we are getting in our country. If you see the prevalence of diabetes among adults in India from 1990, if you see this left side, the map, you can see that how many states were having actually less than 4.5% were exactly the incidence or prevalence of diabetes. But in 2016, exactly after 3 25 years, you can see that how it is changed. The most of the states from dark blue to they had become yellow, where the incidence is almost has reached more than 7.5%, and some of the states like Kerala, Tamil Nadu, and Punjab had shown the data where the incidence had increased more than 10% also. So the prevalence of diabetes in our country is increasing like anything. We have 1 in 11 adults have diabetes. 1 in 5 people have diabetes in the world acutely come from Southeast Asia. 1 in 6 adults with diabetes in the world come from India. 1 in 2 people with diabetes remain undiagnosed. And this is very important. And for this reason, we started or we thought of doing a campaign for defeat diabetes. So the undiagnosed patients, even in rural or urban area, the undiagnosed patients are not less. Even in the urban area also, it is almost like 1/3 to 40%, while in village still we have 50% of them are undiagnosed. So even they don't know whether they are diabetes or not, and that is what our testing, we want to test more and more person to come. They should be knowing the diagnosis, they should know that they are diabetes, and then we can treat them aggressively for the same. So 50% of them are undetected in our country. The age profile of the patients, we know that older persons are there 27.8%, but this working age group is a major problem or major challenge for our country, that between whatever the number of persons who are having diabetes, 72% of them are between 20 to 64 years of the age. The control rates in our country is suboptimal. So the second big problem after this, who are undiagnosed in our country, the second major problem are those even who are taking treatment, those who are knowing they are diabetes, still their sugar are not controlled. And that is what 70% of diabetic patients in India have A1C of more than 7%. This is an ICMR INDIAB data in 2014. So that's 2/3, almost 70% of the patients who are not having under good control of the diabetes. This is the data which we had seen in 2020. Even after in 2014, I had shown you the data. In 2020, this is after 6 years, still what we are seeing, only 22.5% of the patients are exactly having a good control of the diabetes. So still we have almost similar number, which is 76 or 77.5% of the patients are still not under good control of diabetes. So the data which we had seen in 14, we had seen in 18, even the data is almost similar type of thing. So we have a higher prevalence of our diabetes, but relatively low awareness. And this is the major problem for our country. I had shown you in the data that we are increasing number of diabetes in our country. We have 50% of them are undiagnosed. But still the problem is we have low awareness for early diagnosis, low awareness for good control of diabetes, and most of them are not monitoring the sugar also regularly. And there is a bi-directional association between diabetes and COVID. I need not to talk about it because all of us know that those who are uncontrolled diabetes, those who have sugar which is not controlled or first time detected diabetes during hospital stay also have poor outcome in terms of more hospitalization, more hospital stay, more in ICU, and even more mortality also. So this is one paper which is very interesting, and that is, I think, the background for this Defeat Diabetes campaign, that blood glucose level should be considered as a new vital sign which is indicative of prognosis during hospitalization. I was part of it. Jyoti Dev, Anup Mishra, and myself had thought of this writing of this paper that blood glucose is monitoring is actually fifth vital sign. And this paper, a similar type of paper was there also in diabetes care before some time. And we thought of also that in India, the glucose monitoring is not done at all. With the way the patient's pulse, blood pressure, respiratory rate, or the oxygen saturation is measured the similar way, each and every person who is coming to the hospital, the sugar should be monitored. It should be like a fifth vital sign for each and every one. And that is what we had just shown the data that patients who are getting hospitalized, particularly this COVID time, we had seen those who have first time detected diabetes or uncontrolled diabetes found to have worse outcome in compared to the persons who are well controlled or those who are non-diabetic. So this is the reason that this fifth vital sign, we want to make it more popular. We want more and more person should know that sugar monitoring is very, very important, whether somebody is non-diabetic or diabetic. For diabetic patient, it should be regular monitored and they should achieve the target control. And those who are not detected, they should try to take the sugar testing more often. So the Defeat Diabetes is a campaign which we thought of under the RSSDI. Next 100 days, we should reach to 100 million. This is already started with 50 days. So 50 days is already over. We had a mission that test, track, and treat are 3 pillars of detecting diabetes. And our mission is to reach 100 million people in 100 days. This was our campaign. We had created a task force across the country from all part of the country, North India, South India, East India, West India, and central part of the country. Along with our secretary, we had created this task force. And then there is a champions from all across the country who become the partner in this. More than 500 doctors are already campaigning for this Defeat Diabetes campaign. And now 5,000 doctors from RSSDI had already agreed to do this testing campaign regularly in their clinic, and particularly on 29 September when World Heart Day is there. On that day, we are looking for 1 million testing to be done. This campaign we get inaugurated by our Chief Justice of India, Dr. N.V. Ramana, on 1st July on the Doctor's Day, and then it was picked up by almost all media, electronic, public, and everywhere it was there. In all public platform it was there. On social media it was there, and on first day only, we could have almost 1 million people have this tracking, the task track, and this had become a trend on our Twitter, on Facebook, and everywhere it was there. So the launch of RSSDI, this campaign was very, very successful on the first day. And then all the doctors across the country who started working on it, they were on Facebook Live, they were on Instagram Live, and they were talking about the same. We had created multiple videos, multiple these creatives just to make people aware about this. And then we had come out with a petition. The petition was that whether we should put that glucose monitoring is a fifth vital sign or not. So we asked everyone, not only the doctors, from the laymen also, this petition is that sugar monitoring is a fifth vital sign, and already more than 100,000 people have already signed for this petition also. So declaring blood sugar is a fifth vital sign, and that sort of a petition was there. It is those who have not signed, please sign. Is a this petition is a declaring the blood sugar is a fifth vital sign. On this 1st of October, we are sending this petition to the World Health Organization to put that whether we can really write it as a fifth vital sign. There are multiple papers which shows that sugar monitoring is very, very important, even who are non-diabetic or diabetic or getting first time hospitalized for that. And on this basis, ICMR actually had come out with a guideline. And on the same thing, that what they are saying, that each and every patient who is getting admitted, immediately sugar is to be monitored. The way we are monitoring the temperature, the pulse, the blood pressure, respiratory rate, or oxygen saturation, simultaneously sugar should be monitored. So this is what the sugar should be monitored for each and every. This is what ICMR recently guideline just published before 15 days. So they also talking the same thing, that sugar monitoring is very, very important. This campaign which we have done, and we could reach in only in 30 days, only in first month, only 25 million we could reach, 3.5 million engagement, 28.2 million impressions were there because of this. On World Heart Day, we are planning to have one mission with 1 million sugar should be tested on that particular day. Already we had planned it, and it will be a world record. It will be on Limca Book of Records that we are going to have. We are going to have the campaign on radio also to talk about more about this Defeat Diabetes campaign. We all know the role of blood glucose testing in our diabetic patient. It provides data to the person with diabetes that can be used for self-dose medication, for self-adjustment of medication. It provides average that give the person with diabetes rough information that how well they are doing. It reminds the person with diabetes that they have the disease, perhaps altering the behavior. It is used by the healthcare providers to evaluate and make changes in diabetes design of the patient. The self-monitoring of blood glucose in India is actually speaking very, very small market. Very few number of patients are exactly using the self-monitoring of blood glucose. Even if you see 0.1% of type 1 diabetic patients in our country are using SMBG. That's an issue. And for type 2 diabetes, very, very less number of persons are using. So the type 1 who should ideally measure his or her sugar twice in a day, they are not measuring even once in a week. That's what sort of a condition in our country. So the tracking, the monitoring is very, very important, because that timely reflect the influence of diet, exercise, stress, and drugs. So just one time testing is not sufficient. We have to track, we have to monitor it regularly, because a lot of factors which are responsible for changing the blood glucose reports, and that's the reason it has to be tracked regularly. It provides the necessary data for evidence-based clinical decision-making by healthcare professionals. It is an effective tool for managing diabetes, so regular monitoring associated with reduced blood glucose level can improve the quality of life. So this is what we want, that not only those who are to be tested, but those who are diabetes, they should regularly monitor. Even once their sugar may be controlled, but still the sugar continuous monitoring is very, very important. It could be done with the self-monitoring of blood glucose. Implementation of blood glucose monitoring is far from world as far as satisfaction is concerned. The new concept had come, that is time in range. We know that we can't afford for all our patient continuous glucose monitoring. We can't afford the newer CGM device, but for some of the patients who can afford, or those who need it, the CGM device, if we put the continuous glucose monitoring, a new parameter which we can talk to our patients, not just the sugar report, the time in range, and how much time in out of 24 hours they can remain in that time in the range between 70 to 180. What the international guideline is talking, they should be in 70 to 180 more than 70% of the time, and that is the time in range is a key metric for the quality of good glycemic control. The targets are very, very clear. For type 1 and type 2, it should be more than 70% of the time. They should be in the time in range, while the persons who are older, high risk for hypoglycemia, or type 1 and type 2 who can't have because of severe hypoglycemia or hypoglycemia unawareness, is still more than 50% of the time, they should be in this range of 70%. We know that there are multiple complications which diabetes patients can have, and that is what the complete reason why we are talking to our patient, that after testing and tracking, why they should achieve a target control. It is not just that diabetes can reduce the macrovascular complication. We know that macrovascular complication may not be prevented 100%, but yes, definitely microvascular complication significantly can be reduced. With the single 1% A1C reduction, there is a significant reduction in microvascular complication that we know from our UK PDS data to advance and echo data too. So that reducing A1C will definitely reduce the microvascular complication, trying to achieve a target A1C, and that information that everyone should know, all the laymen, why they are keeping their A1C with 8.5 or 9. I mean, there's no reason for that, and that we want to create a awareness in the society, achieving a target A1C of less than 7. So this is what we want, the testing, more tracking, and then achieving a target A1C for most of our patients. So now a new a triad which we know from fasting plasma glucose to HbA1c to the postprandial glucose level, we moved from there to the tracking, which is continuous glucose monitoring, to know from that the glycemic variability should be low, the time in range more than 70% of the time they should be there, and no hypoglycemia, because hypoglycemia is a major limiting factor for most of our patients not to achieve a tighter glycemic control. So what we want for our patients to move from a glycemic triad, which is fasting, post-meal, and HbA1c control, to the a control of glycemic variability, more to achieve a time in range, and no hypoglycemia and better quality of life. With this Defeat Diabetes campaign, we want our patient more and more to be tested. We want more and more patients who should be tracked for it regularly for self-monitoring, for continuous glucose monitoring, and they should achieve a target of not only A1C, but also time in range. And this information which we want to give through social media campaign and to reach 100 million persons. That was the complete idea of this campaign and the mission of it. And we almost successful in last 30 to 40 days, and this month and probably in first week of October, we will able to reach to 100 million persons. That is what our target will be achieved definitely. And on 10th October, we will be doing one more program that what we achieved in last 3 months. But this we cannot complete, or we cannot stop the Defeat Diabetes campaign just at the 100 days, because this campaign is to be continued. We want our persons, those who are diabetes or those who are caregivers or those who are even non-diabetes at the risk of developing diabetes, to know more about the diabetes, and through social media campaign, we will continue with this. So the 100 days Defeat Diabetes continue. It will be there with us. Those who are reaching to the doctor for anything else, there should be opportunistic screening. Those who are having diabetes, they should be tracked, and they should be having a treatment to achieve the target control of the diabetes also. With this, I once again, thank you, Dr. Vishwas, for giving me an opportunity to talk on this very ambitious campaign of RSSDI Defeat Diabetes campaign. Thank you very much.
Thank you, Dr. Banshi Sabu, and especially the RSSDI for taking this initiative on making ICMR recognize this diabetes blood glucose testing as the fifth vital sign. That is a very welcome approach to management. And of course, I'm sure there will be many more questions later on, but I think we can move on to the next talk. The questions will be at the end of the session. So I think the next talk, I request my co-chair to please introduce the next speaker.
Good evening, everybody, and it's my pride privilege to introduce a very well-known face in diabetes area of diabetes, and he is Dr. none other than Dr. Sujay Ghosh, who is DM endocrinology, and he has FRC, FACS, FICP, FRSSDI. He is consultant senior diabetologist and endocrinologist, Kolkata. He is associate professor of endocrinology at IPGMR, Kolkata, and Amri Hospital, India. So, without wasting much time, I hand over the session to Dr. Sujay Ghosh. Sir, kindly start your session.
Thank you so much. And at the very outset, I would like to thank the organizers for having given me this wonderful opportunity to speak before you. I only have one request, that I be allowed to answer the questions and answer immediately after this talk, because I have another talk thereafter. So I have been asked to speak on peptides in a pill. Hopefully my slides are visible and I'm properly audible. So I have been asked to talk about peptide in a pill and the development and clinical journey of oral semaglutide. Now this talk, I understand, is a sponsored talk of Novo Nordisk, and the slides have been provided to me by Novo Nordisk themselves. So this is a brief outline of my talk. I'm going to talk about the role of GLP-1 receptor agonists in management of diabetes. I'll talk about the Pioneer program, which is forming the backbone of the oral semaglutide program, and the pioneering management in routine clinical practice, a little bit about the practicalities, because we are all getting up, ready, gearing up for oral semaglutide to be launched in India. So if we talk about the first bit, I think if you look at the history of drug delivery and drug development of diabetes, Fomik was talking about insulins, and you can see what started 100 years ago. The first 60, 70 years were pretty quiet, but just after the 1990s, in the mid-1990s onwards, we have so many drugs which have been discovered in the management of type 2 diabetes. And not surprisingly, the more drugs that you discover, the more guidelines you have about the drugs in management of type 2 diabetes. So the last, particularly 20 years, has seen an explosion of drugs development in diabetes management. And what has been an ideal quest for finding an anti-diabetic agent is we are trying to walk on a tightrope, wherein you're trying to minimize hypoglycemia and yet lower blood glucose, cutting down on the weight gain that happens with most of the drugs that we use for management of diabetes, and try and avoid side effects and off-target effects. And at one point of time, your A1C, the targets were much more lax and loose. But now what we've realized, we've kind of looked at targets closer to 7 and maybe in near future even lower than that. We want to lower the risk of hypoglycemia. We want to achieve good glycemic control, minimize off-target effects, and minimize weight gain and preferably weight loss, and achieve good glycemic control and CV safety. Now, if you look at the ominous octet of Ralph DiFronzo and look at where GLP-1s figure in that 8 mechanisms of action, you will see that the GLP-1s are doing pretty well in trying to address at least 6 out of those 8 mechanisms. in which particularly if you look at liver, it reduces hepatic glucose production, increases liver sensitivity to insulin, improving liver fat and decreasing lipogenesis. It might have cardiovascular protection and vascular protection. At the level of the brain, induces satiety and therefore people eat less and causes weight loss. In the pancreas, there's decreased glucagon secretion, augmentation of insulin secretion. In the gut, there is reduced gastric emptying, and the muscles, there's increased insulin sensitivity. And there are now suggestions to suggest that there might be even improvement in natriuresis and renal protection. Now, if you look at the data in terms of the oral peptides that we're talking about, we realize that there are significant unmet needs because, we want to use drugs which will be better tolerated and can be used early on in the management of diabetes per se, and which will not be injectable. But our wish is not necessarily always fulfilled, because when we take some oral medication, what often happens is this group of drugs get damaged enzymatically by degradation in the stomach because of low pH and presence of proteolytic enzymes. What often happens also is that the drugs have limited permeability across the GI epithelium, and because of low bioavailability of the oral GLP-1s, the drugs have not been working in the past. So there has been limited absorption of conventional GLP-1s. So scientists have found out certain ways and means by which this or these barriers have been overcome. That semaglutide, which we know is a human GLP-1 analog, is getting tagged, and this is a drug which is one of the best GLP-1 receptor agonists and has got a long half-life up to 1 week. And scientists have found an absorption enhancer, and that is sodium 8,2-hydroxybenzyl aminocaprylate, which will promote the absorption of semaglutide across the gastric epithelium by altering the local pH and enhances the bioavailability of semaglutide. And what essentially has been done in the oral semaglutide drug is that you've got semaglutide on one side and you've got the snack on the other side in that one pill, which increases absorption of the drug. Now, the pioneering study of oral semaglutides, if you look at, there are several trials that have been done with semaglutide. There's one phase 2 trial, and there are about 10 phase 3A trial, and almost about 6,000 individuals have already been exposed to oral semaglutide. And if I just summarize very quickly the phase 3A trial program, the Pioneer 1 is about, it's a placebo-controlled trial versus diet and exercise. Pioneer 2 is in comparison with empagliflozin. Pioneer 3 is comparison with sitagliptin. Pioneer 4 is versus liraglutide and placebo. Pioneer 5 is in individuals with renal impairment other than end-stage kidney disease. Pioneer 6 is a CV outcome trial to prove CV safety of the drug. Pioneer 7 is a flexible dose adjustment versus sitagliptin with an extension. Pioneer 8 is with an add-on to insulin therapy. Pioneer 9 and 10 are in Japanese studies, one looking at comparing it with liraglutide and the other with dulaglutide. And we also, of course, have the SOUL study, which is ongoing, of which IPGMER is one of the centers to try and show a CV outcome superiority of oral semaglutide compared to placebo. Now, if you look at each of these trials of the Pioneer program, at least the ones that are completed, and you are trying to look at certain aspects, let us first look at the A1C lowering and the weight reduction bit. So Pioneer 1, as I said, was a monotherapy comparing against diet and exercise placebo group. You can see, depending on the dose of oral semaglutide that you're using, the A1C reduction is as good as minus 1.5% reduction, and the weight loss could be to the tune of up to 4 kilograms. Now remember, the baseline in these individuals of the weight was around 90 kilograms, about 88 kilograms. And for the A1C, the starting was almost close to 8%. In the Pioneer 2, you can see that it was against empagliflozin, again a 1.3% reduction in A1C and almost a 4 to 5 kilogram weight loss. So you can see that the A1C reduction compared to empagliflozin is significant, though the weight reduction is probably similar. Again versus sitagliptin in Pioneer 3, A1C reduction is far superior with oral sema compared to sita, and the weight reduction is significant. If you look at Pioneer 4, which is a comparison with liraglutide, again, oral semaglutide seems to be doing better, both in terms of weight reduction and A1C reduction, compared to 1.8 milligram of liraglutide. Pretty dramatic results there as well. And again, the renal study of Pioneer 5 showing that it is safe and reduces weight as well as A1C. The Pioneer Flex, which is an extension of the CETA study, again showing similar results, and Pioneer 8, which is again with insulin. So all across, in most of the studies, you can see it has better glycemic control compared to all of the comparators. And in terms of the weight, only empagliflozin is probably producing non-statistical difference in terms of weight compared to oral semaglutide. The rest, oral semaglutide seems to be doing better in terms of weight reduction. Now, if you look at an post hoc analysis of looking at semaglutide 14 milligram, and if you look at the kind of HbA1c reduction that you have across, the A1C reduction with 14 milligrams of oral semaglutide is close to 2%. And if you look at Pioneer 1, it is as high as 2.6%, because there the baseline to start with was 9%. So anywhere around 1.5 to 2.5 A1C reduction with oral semaglutide 14 milligrams. That's pretty dramatic results. Now, if you look at Pioneer 6, which was basically a non-inferiority trial to show CV safety of oral semaglutide, you can see that this is a study conducted in individuals above the age of 50 with established cardiovascular disease, or individuals above the age of 60 with at least one cardiovascular disease. There was significant reduction in A1C and weight, and the drug was relatively well tolerated, and there was a 21% non-significant reduction in the 3-point MACE with significant trends toward reduction of cardiovascular mortality. And in that very study, like I said, there was very good reduction of A1C as well as reduction in weight. Now, if you look at a meta-analysis of oral and subcutaneous semaglutide put together, though I'm not very sure that we should be doing the same, there is a trend towards significant risk reduction of the 3-point MACE. But it's best that we wait for the SOUL study to tell us whether oral semaglutide can reduce cardiovascular events and 3-point MACE. So if I kind of summarize the already completed phase 3 oral semaglutide studies, we can clearly show that as far as the A1C reduction is concerned, apart from liraglutide, where there was non-inferiority, the rest, there is significant reduction in A1C. And in terms of the weight, like I said, for all of the drugs, oral sema seems to be reducing more weight, except perhaps empagliflozin. And already, like I said, Pioneer 6 showed CV safety of oral semaglutide, and oral safety was relatively well-tolerated drug in terms of the drugs that we are talking about. Let us look at now a bit of the data of the combination of data will be add to the overall CV evidence that is going to be there. So all of the studies that are there in the pipeline. So like I've said, you already have SELECT and SOUL, which will tell us about the cardiovascular outcome. In terms of the renal outcomes, we have the FLOW and the SOUL study, which are in place. And in terms of the PVD, again, you have the SOUL and the FLOW. So we await patiently for the outcome of these results. And again, the heart failure preserved ejection fraction trial, the CV mechanism of action trial, the renal outcome trial, and the PAD trials. Now coming to certain practical aspects which we doctors need to know, because unlike a lot of other oral agents, this has certain practical issues in terms of the way we administer the drug. Now, because I've said the SNAC enhances the absorption of oral semaglutide, and because bioavailability is an issue, there are certain precautions that we need to follow for this drug. So the first thing that you do on waking up in the morning, you will have to take the semaglutide tablet with about half a glass of water. Thereafter, you cannot have anything to eat or drink for about half an hour. And there, after that, you can have your first meal and drink of the day and take any other medication that you require. And in terms of the practicalities of the dosage of the drug, one is supposed to start with 3 milligrams as an initiation dose. Remember, this is not a maintenance dose. You're starting a 3 milligram low dose because you want the individual to tolerate the drug better in terms of the GI side effects. After a month, you up titrate the dose to 7 milligrams of maintenance dose. And in individuals where you want the greater efficacy in terms of A1C and weight reduction, you switch over to a 14 milligram dose. That is probably the optimal dose if tolerated. And that is again after a 4-week period. If an individual forgets to take a dose on one day, then that dose should be skipped for that day and take the normal dose the next day. So that's about the practical bits about the drug dosage. And in terms of the guidelines, I think this is where it will be positioned in future in terms of the recommendations. We still believe as endocrinologists and diabetologists that metformin should be the first line drug. And then you're looking at the CV risk of an individual. If an individual is CV risk, low CV risk, then after the metformin, you are thinking of a drug. You could probably think of oral semaglutide where you are wanting robust reduction of A1C and weight, because we've already said as compared to say sitagliptin or empagliflozin or liraglutide, this seems to be doing pretty well. In individuals where there is high CV risk, of course, think of oral semaglutide because it will not increase CV risk, but it will reduce significantly the A1C and the weight. And you can always think of the stepwise manner of change of medication. We've already talked about no restriction for oral semaglutide, even if individuals have renal dysfunction, and it can be used again in addition with insulin. Now, if you are trying to switch an individual from an injectable GLP-1 to oral semaglutide, then you need to know certain things as well. I will come to that as well. So first of all, where are you going to think of the use of oral semaglutide? In terms of the patient characteristics, you can use it at any point of time in place of, say, a DPP-4 inhibitor or an SGLT2 inhibitor as an add-on to metformin therapy, as a monotherapy, or even as an add-on to insulin therapy, particularly in individuals where you're trying to avoid risk of hypoglycemia. Individuals with liver dysfunction, you can use it safely without any adjustment of dose. You would probably be using it in individuals where you want the individual to lose weight, particularly where the individual does not want to take injectable therapies, and even in individuals with renal impairment, unless and until the individual has end-stage kidney disease. And there is data in even older individuals to show that the drug is equally efficacious. Now, if you're trying to switch to a GLP-1 oral semaglutide, the first thing that you have to do is you have to speak to the patient, counsel the patient with regards to discontinuation of the injectable GLP-1. Now, if it's a daily or a twice daily GLP-1, from that, if you're switching, then you start the oral semaglutide one day after stopping the injectable once daily or twice daily oral injectable GLP-1 analog. And you could be doing this, because the individual did not want an injectable one, or the individual wanted this because was having GI side effects. If the individual was having GI side effects, then after you stop the injectable GLP-1, wait for the GI side effects to settle down, then start with 3 milligrams of oral semaglutide and gradually titrate up to the maximally tolerated dose. Consider lower maintenance dose if required, if GI side effects was the problem. Now, if you are switching from once weekly GLP-1, you could either switch to once daily or twice daily GLP-1, or you could then follow. You could, if you're switching over straight to oral semaglutide, then you stop the injectable and the first dose is administered of the oral semaglutide 7 days after discontinuation. If it is because of a switch, then you can start with a lower dose and titrate according to the product insert that we've already talked about. You could reevaluate every 3 months to see whether the individual is tolerating the drug and whether the drug has been adequately titrated and what the glycemic response and the weight response is. The other thing is that what might be useful from a clinical point of view is knowing the equivalence of doses between the injectable and the oral. Because the most commonly used GLP-1s, at least now in India, is either liraglutide or dulaglutide. Remember, for liraglutide, you have got 3 injectable doses, 0.6, 1.2, and 1.8. Similarly, when you're switching over to oral semaglutide, the equivalent doses are 3 milligram, 7 milligram, and 14 milligram. For the dulaglutide, you have 2 doses of 0.75 and 1.5. The equivalent dose is 7 milligram and 14 milligram. This is predominantly based on expert opinion, but it seems to be doing best in a lot of situations. So there are certain things in terms of communicating and counseling of patient. You have to explain to the patient clearly that the dose escalation is important because it will help the individual to tolerate the drug better. And that is the reason why you start probably with 3 milligram. The patient should have realistic expectation about the weight loss and the HbA1c reduction. There might still be some GI side effects, which you have to talk about. And that most of it is typically transient when you first start. Recommend the patient to avoid high-fat meal, reduce portion size, and counsel the patient to drink enough water, particularly when the individual is having GI side effects. That will help the patient to tolerate. Breastfeeding and pregnancy are absolute no-nos. And if an individual is contemplating pregnancy, then it has to be stopped at least 2 months before planning pregnancy. And oral semaglutide is not recommended during breastfeeding. If there's missed dose, I've already said, forget it for that day and continue with the next dose the next morning. So to summarize, GLP-1s are great drugs in terms of A1C reduction, weight reduction, and composite outcomes. But we will still wait for the SOUL study to show whether the oral semaglutide can reduce cardiovascular events. Oral semaglutide is indeed a breakthrough scientific innovation. And we've talked about the Pioneer program. On an average, 1.5% HbA1c reduction and up to 3 to 5 kilogram weight loss. Remember, it will of course depend upon your starting point of HbA1c. Oral semaglutide can be used either as monotherapy or add-on to metformin, and that the A1C reduction is better than that of SGLT2 and DPP4 inhibitors, and can also reduce A1C when added to insulin therapy. In patients who have very high starting A1Cs, the reduction can be even as high as 2.6%. And like I've said, the oral semaglutide has proven that it is CV safe in the Pioneer 6 study, but we are waiting for the SOUL study to show whether this drug is actually going to be beneficial in terms of CV outcome. The drug is safe in individuals with liver dysfunction and can be used in individuals with renal impairment up to the stage of ESRD. I shall stop there for any questions. Thank you very much.
So thank you very much, Dr. Sujay, for a nice and vivid presentation regarding semaglutide. And I welcome Dr. Banshi, our next chairperson, to introduce our next speaker.
Can I ask a question to Sujay sir, please, chairperson, if you kindly allow?
Ask.
Yeah, sir, thank you, sir, for a wonderful and lucid presentation. So I have two practical questions because we have not still used semaglutide in our clinical practice. So you have mentioned that the pill needs to be taken at early morning in empty stomach. But regarding concurrent administration of some other medicines, which also have to be taken in empty stomach, like we have many patients who are on thyroid replacement, then we have some patients who take weekly oral bisphosphonate. So regarding those patients, what do you suggest? So the timing of the
right. In terms of thyroid, levothyroxine replacement, it has been documented clearly that there is no drug interaction and that the levothyroxine can be taken along with oral semaglutide. But there are so many other drugs that people usually take, whether it's PPI or other medication. As far as the current recommendation goes, you should try and space it out. The other thing that can be interesting is a lot of these drugs that we actually recommend to be taken first thing in the morning, in the Western world, people tend to take it at supper because they take, at bedtime, because they take their dinner or supper at around 6 p.m. and then go to bed at 10 p.m. So as long as there is about a 4-hour gap between your last meal and the drug, all of the drugs that we talk about to be taken on empty stomach in the morning can probably be taken. We don't have such convincing data for oral semaglutide. So for the time being, let us stick to what the recommendations are when the drug is available. You're muted. I think you're muted.
Can I ask a question, Sujay?
Yes, ma'am.
Hey, how this oral semaglutide, how does it compare to injectable semaglutide? Are there any data on that?
Ma'am, we don't have head-to-head trial.
Okay.
But given the fact that our institute has been part of clinical trials of both of them, not myself, but Dr. Professor Shubhankar Chaudhary and Professor Shwetinath Mukhopadhyay, I've had the fortune to speak to them. They seem to be very, very happy with the kind of A1C reductions that are probably happening with the oral semaglutide. From my end, I think there are 2 things or 3 things that I would actually like to know once we start using the drug. One, of course, is the CV outcome in the SOUL study. Are we able to replicate the superiority data? That's going to be one big issue. Second is what is going to be the price of the drug. And the third is going to be what is going to be the GI tolerability. I think we will know this within, once the SOUL study data is out and once we start using the drug for about 3 months, we will know about the other 2. So depending on these 3 factors, I think we will probably be able to position the drug in clinical practice.
Thank you. I think there are no more questions, I think, in this.
Thank you, ma'am, and thank you, my respected chairman.
Yeah. Thank you.
So, Dr. Binod, our next chairperson, can you introduce next speaker for the session?
I'd like to invite now Dr. Deepak Zumani for his talk over how to evaluate the patients of erectile dysfunction in type 2 diabetes mellitus. Dr. Deepak Zumani is senior sexual health physician and counselor, and he is attached with Sir JJ Group of Hospital and Grant Government Medical College, Mumbai, and he is the post director and mentor and awarding fellowships in clinical sexology. So now over to you, Dr. Deepak Zumani, please.
Thank you, Doctor, for that very kind introduction. At the outset, I thank Dr. Biswas and his whole team for giving me an opportunity to share my views, thoughts, concepts, and passion. With pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Prakash Kothari, and Sashank Joshi, I beseech them to bless me always. I have no conflict of interest and I have some breaking news to give. Most common cause of mortality in men is due to cardiovascular disease globally, and men live 5 years younger than women. 45% men are dissatisfied with their sex life. Most common cause of divorces in India are due to male impotence. A beautiful female study, which is nothing but females' experiences of men's attitude to life, events, and sexuality. These are all the experiences of women whose husbands or whose partners had erectile dysfunctions. Some said that some women felt they can obtain sexual gratification even without good erection, but if they had good deep level of non-sexual intimacy. Some women questioned that they were not attractive enough to attract their partners. Some women felt that their partners had some lafda. Some questioned the worth of the relationship to be sustained and wanted to separate. Some women felt that sex was something to be avoided. What will they do at this age? But most of them agreed that their quality of life was affected. There was frustration, there was sense of inadequacy, self-blame and insecurity. COVID-19 is now also to be proven as an endothelial disease. The flaccid truth is that endothelial dysfunction causes erectile dysfunction and erectile dysfunction causes emotional dysfunction. And the bitter truth is that all these are the manifestations of aging and age-related complications which include diabetes. What happens in aging? Antioxidative system sparks off, angiotensin 2, TNF alpha, mechanical pressure, and uncoupling of endothelial nitric oxide synthetase all lead to production of reactive oxygen species, which decrease the nitric oxide production, leads to nitric oxide inactivation, and ultimately leading to endothelial dysfunction, which manifests as vasomotor smooth muscle growth, inflammation, remodeling, apoptosis, and altered vasomotion of the blood, and ultimately leading to vascular complications. So, if aging is a disease, are we not living in disease state? Yes, we are. But the main feature of aging process is a chronic progressive increase in the pro-inflammatory status. Now, this is controlled by a network of cellular and molecular defense mechanisms. When this system goes bad, we become immunosenescence. And what is it? It is nothing but adaptive net result of our body's defense mechanism, which itself is in a dynamic process. So I call it inflammaging, which is due to stress or oxidative inflammation, cytokines, DNA damage, all through various signaling pathways ultimately lead to imbalance of inflammation and homeostasis and lead to inflammaging. So diabetes also is an inflammaging disease. Because of diabetes, there is hypoglycemia, high TNF alpha, PKC activation, endothelial nitric oxide synthetase reduction, ROS, and this activation of RhoA, which increases the capillary permeability, arginase 1, arginase reduces the L-arginine production, reduces vasorelaxation, and ultimately leads to endothelial dysfunction. Our first study done in KEM with diabetics, all males had erectile dysfunction, premature ejaculation and low desire, and females had low desire and depression was the common thing seen in them. What is erectile dysfunction? It is inability to attain and sustain erections in most of the encounters, but it should be at least for 6 months and there should be good clinical distress. This is a schematic diagram of the physiology of erection. That's the vascular endothelium producing endothelial nitric oxide synthetase, which potentiates or the nitric oxide, which is the main chemical signaling molecule or the currency of the cell or the miracle molecule which enters, diffuses into the corpora cavernosa smooth muscle cell, converts guanosine triphosphate into cyclic guanosine monophosphate with the help of an enzyme called guanylyl cyclase. This cyclic GMP through protein kinase G mechanism relaxes the smooth muscle of the corpora cavernosa cell and allows the blood to flow inside the penis. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So if you look at the physiology and if you want to have a good erection or good give therapy to patients, we need to understand it is the endothelium which is responsible for producing endothelial nitric oxide synthesis. So anything going wrong with the endothelium, everything is an aftermath of it. So erectile dysfunction is an endothelial dysfunction. In diabetes, there is a possible and definite link of erectile and endothelial dysfunction. It is psychogenic, vasculogenic, neurogenic, hormonogenic, drug-induced, and even genetic today, because they found a SIM1 gene, which is located in our genes, which signifies association of the risk of erectile dysfunctions. It is proven beyond doubt that endothelial derived nitric oxide is nothing but anti-atherosclerotic molecule and anti-thrombotic molecule. Also, erectile dysfunction is nothing but subclinical cardiovascular disease. Diabetes is prevalent in India and China. India and China are the capital of diabetes in the world. So Chindia is the capital of the diabetes in the world. And erectile dysfunction is the commonest complication of diabetes. So Chindia are the erectile dysfunction capital of the world. Both type 1 and type 2 have an increased risk of erectile dysfunction. In MASH male aging study, diabetes showed 3 times probability of having erectile dysfunction compared to non-diabetics. The molecular basis of diabetes associated erectile dysfunction is there is something called as turning on of RhoA, Rho kinase, which produces complete vasoconstriction in the whole penile vasculature. There is also assessment in the rats, which they found out there was decreased expression of anti-apoptosis gene BCL2, which was responsible for shift in the cellular homeostasis and shifting towards cell death and organ degeneration. How do we manage erectile dysfunction in diabetics? Rule out the psychogenic cause by asking one simple question, that does he have problems in making love, or does he have get up in the morning with erections? If he is getting up in the morning, does he get morning erections or morning tumescence? He is normal, because in deep REM sleep, every male gets 3 to 4 erections which last for 15 to 20 minutes if he has got no organic issues. And if he is having erections in the morning, he has got psychogenic or situational erectile dysfunction, which does not need treatment. He needs counseling. We have two beautiful questionnaires, IIEF and SHIM. We advise, according to Framingham study, on smoking, diet, hypertension, lipids, sugars to be controlled, HbA1c to be less than 7. Eye, feet, and oral hygiene to be examined every time when the patient comes to you, especially diabetics. Put them on guardian drugs like aspirin, ACE inhibitors, and do the cremasteric reflex and bulbocavernous reflex. Oral office sildenafil 50 milligram or intracavernous papaverine, we do give to rule out psychogenic and this thing. We also do additional tests in diabetics is serum testosterone free and total, sex hormone binding globulin, thyroid, estradiol, vitamin D, uric acid, phosphorus. We also advise sonography of the scrotum, Doppler studies, serum PSA free and total if we have to give them testosterone, digital rectal examination, and Regiscan. Salivary tumor necrosis factor alpha, just by putting a swab on the gums and seeing it in the slide, you can diagnose erectile dysfunctions. Platelet lymphocyte ratio on a CBC, if the platelet lymphocyte ratio is more than 105, he's got mild erectile dysfunction. If it is more than 116, moderate. If it is more than 136, he's got severe erectile dysfunction. So just by looking at a CBC, you can do a mental calculation and diagnose erectile dysfunction in your diabetic patients. And then you can confront with him. He will call you to be a Sai Baba. How did you know about it? Every diabetic has advanced glycated end products. And this gadget, you just put your hand on this machine, and through skin autofluorescence, you can diagnose erectile dysfunction in diabetic patients. How do we treat? The first line of treatment is oral drugs, counseling, and lifestyle measures. Second is injection of papaverine, vacuum therapy, intraurethral drugs, counseling, and lifestyle measures. If all these fail, we send our patients for transplant, implant, and anastomosis surgery. But counseling and lifestyle measures form the mainstay of treatment for erectile dysfunction. We have 4 PDE5 inhibitors, sildenafil, vardenafil, tadalafil, sildenafil, have varied onset of action and duration of actions. All of them have side effects of facial flushing, headache, nasal congestion, visual disturbances, and the common contraindication is nitrates or hypotension or any anemias or leukemias. Best for every diabetic today, proven beyond doubt, is low dose tadalafil for 12 weeks, irrespective of whatever is his HbA1c, hypertension, prostatic hypertrophy, or even dyslipidemia. This has shown beautiful results in their sexual functions. My friend Dr. Jyoti Dev has given patients insulin pump and has found 83% improvement in their sexual dysfunctions. Metformin, which is now proven to be an endothelial dysfunction improvement in patients who are on metformin, and this can be given adjunct to patients who have got erectile dysfunction. SGLT2 inhibitors, because of its class effect of losing weight, controlling hyperglycemia, hypertension, dyslipidemia, and many other important features. We published this data and we found that these patients who are on SGLT2 inhibitors and metformin, they got normal physiological erections and they did not need PDE5 inhibitors. Buried penis syndrome, very common to see in our day-to-day practice, improves with 1 gram of metformin, sesame seed oil, and L-arginine gel application on the shaft of the penis. Newer treatments include low-intensity extracorporeal shockwave therapy, platelet-rich plasma, but we lack a lot of robust evidence, and these are good only for mild to moderate erectile dysfunctions. There are novel markers which will be soon hitting the market, but stem cell therapy and platelet-rich particles have been tried even in India. What is important to understand that certain nutraceuticals like L-arginine and fenugreek in saponized form have shown to improve lipid metabolism and glucose metabolism in patients with obesity and diabetes, and also improve the androgens. What is new in medical treatment is avanafil. The fastest onset of action is in 15 minutes, and it has got less PD6 and PD11 inhibition, so less visual side effects and less myalgia, and the half-life is 5 hours. So this can be easily given to patients who are on nitrates by skipping the nitrates on that day, and so in 5 hours this drug is washed out. It has been tried in diabetics and has shown better sexual encounter profile. Even the second encounter is better. Mean IIEF domain scores improve, and the onset of action is just within 15 minutes. Novel molecules which will come soon are SLX2101, mirodanafil, lodanafil, very good in effect. But we need to think, these patients, do they come for a symptom of erectile dysfunction, or they consider it to be a disease? If they come as a symptom of a disease, we need to give them pharmacotherapy. But if they think that is a bigger disease than the diabetes, we need to give them regenerative therapy or phytonutraceuticals. So the current approach what we have does not offer cure, or most of them are not effective. So what we have in the pipeline is stem cells, and there have been beautiful studies done. They took umbilical blood stem cell and transplanted in the intercavernous tissue, and 7 diabetic men who failed erectile dysfunction medical therapy of the age between 57 to 87, 6 out of 7 got morning erections within 3 months, and they also improved in their insulin resistance. So my last part of my talk is, please friends understand that PD5 inhibitors are therapeutics, because of PD5 there is a PKG activation, and there is antioxidant enzyme increase which improve the mitochondrial functions by reducing the reactive oxygen species and improving the contractility of the heart and cell death. So this is important to understand, that PD5 inhibitors not only improve the endothelium functions but also improve the mitochondrial functions. Favorable effect of SGLT2 inhibitors and metformin we have already told you. Recent direct study showed that diabetes can be remissioned by just lifestyle measures and diet control. Paresh Dandona from Boston proved beautifully that long-term testosterone therapy in type 2 diabetic with hypogonadism improved their insulin resistance and glycemic control, and there was remission of diabetes in these patients. Dean Ornish proved long time back that coronary artery disease were improved with just intensive lifestyle measures. And we understand that most of the risk factors are all modifiable risk factors. They are either diet, sedentary lifestyle, or smoking or tobacco. And the current approach has to be to, we can improve every risk factor, be it smoking, be it BMI, be it physical activity, be it lipids, be it diabetes, be it hypertension. But one thing because of which the cardiovascular deaths are still rising is the healthy diet score. We Indians lack in healthy diet, and that is responsible for the increased incidence of cardiovascular disease in our. And even Cleveland Clinic beautifully said that nutritional intervention in most of the patients not only halted but even reversed the coronary artery disease. Look at this perfusion scan, how beautifully it improved just with nutritional intervention. Such a huge plaque without stenting has been opened up only with lifestyle. It is no point in treating your patients for erectile dysfunction after he gets angina or after he's done angioplasty or bypass. The skill or the clinical acumen or the beauty of a physician is if he diagnoses erectile dysfunction before 30 years of age and retards the onset of these critical events in his life. So the doctor of the future will no longer treat human frame with drugs, but rather will cure and prevent disease with nutrition. Two-time Nobel Prize winner said nearly all diseases can be traced to a nutritional deficiency. It is a shame for a man to grow old without seeing the beauty and strength of which body is capable of. Friends, you can challenge your patient's body, counsel him so beautifully that he goes for exercise, he controls his diet and reduces all the risk factors. My take home message is, give your patients realistic expectations. Don't guarantee them cure, but guarantee them that you will do everything possible, guaranteed 100% which is required by you, but cure you should not guarantee. Now one last important slide of mine is that, is endothelial dysfunction reversible? Yes, it is, with the help of statin, ACE inhibitors, antioxidants, L-arginine, estrogen therapy, proven beyond doubt, along with lifestyle measures and counseling. You find 4 weeks of L-arginine improved the endothelial dysfunction, just 4 weeks of using L-arginine. So potentially The most exciting future direction relates to improvement of arterial endothelial function in children and young adults early in the atherogenic process. Intuitively, it is at this early stage that arterial wall damage is most likely to be easily reversible. So, if strategies to protect the endothelium early in the life can be defined, or if the mechanism is available, which it is, it and applied successfully, this may be an important public health benefit into the next millennium. So, whatever be the cause, erectile dysfunction, low desire, testosterone can be given, early ejaculation can also be improved with counseling, depoxitin. Lifestyle measures should become your first religion, because what healthy lifestyle will give you? Reduction in the pro-inflammatory milieu, reduction in the insulin resistance, reduction in the oxidative stress, and also improvement in the endothelial functions. This will improve his well-being and reduce the burden of sexual dysfunctions. What an ideal prescription of a diabetic should be: counseling, lifestyle measures should be adopted as soon as possible. OHAs, insulin, whatever you want to give, but prefer metformin and SGLT2 inhibitor. Statins is a must. If you want to give antihypertensives, ACE inhibitors, ARBs are the best. Otherwise, give them nebivolol. If you have to give beta blockers, if you have to give diuretics, indapamide is the best. Low dose PD5 inhibitors if there is no contraindications. Short course of testosterone if no contraindication, but monitor with PSS. L-arginine supplement with fenugreek and zinc, beautiful. Nutritional intervention counseling is a must, and mental health checkup is also a must. So we have 4 PD5 inhibitors. They do not increase the desire, but 40% of these patients are non-responders. So we have the testosterone, who's the basha of all. But we need to give it with caution. We need to be fearing about azoospermia, heart failure, or prostatic issues. So the raja of all is L-arginine and fenugreek in a saponized form, and lifestyle modifications will give him erections, will give him a desire, will also improve his atherosclerosis, which is causing. You need to understand there should be no conditions in love. You are partners for life. Feminism needs to be adored, admired, trusted, and respected. Men have erectile dysfunction, early ejaculations. They don't take treatment. They deprive their partner of the pleasure which she deserves. This is bad. Feminism needs to be adored. There should not be a disregard to your partners. Erectile dysfunction in diabetes is not an option for anyone. It is how gracefully we handle the process and how lucky we are as the process handles us. So, if you detect erectile dysfunction as early as possible, it is a blessing in disguise, because you can reverse the metabolic syndrome, give him lifestyle modification counseling, put him on L-arginine and fenugreek, and then erectile dysfunction is surely a correctile dysfunction. So my last slide is, this is my book, Sex Has No Expiry Date. My last slide, erectile dysfunction is very common in diabetics. It's a tip of an iceberg. It's the earliest marker of coronary artery disease. Is an endothelial dysfunction. It is diabetes type 5. PD5 inhibitors and short course of testosterone are ideal. L-arginine supplements and fenugreek is a boon. A heart that loves is always young. Age, weight, height are just numbers. Lifestyle measures can reverse metabolic syndrome. Erectile dysfunction, hence, is a correctile dysfunction. And if so, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.
Very nicely elaborated, Dr. Zumani.
Thank you, sir.
And it has been supplemented with some beautiful pictures and plethora of knowledge.
Thank you, sir. Hope I was on time.
Yeah. So the podium is open for the questions. If anybody wants to ask or put some queries, please go ahead.
So there are a few questions in the chat box. I want to ask our speakers. First question is, sir, which protein gives control of glucose? That is from Dr. R. Mukherjee. And my question is to Dr. Banshi. So, sir, kindly tell your experience regarding which protein gives better control of glucose. Dr. Bansi is there, or else Dr. Smith can answer again, which gliptin gives better control of glucose. So I conclude the
think
session here.
I
Ma'am,
think Dr. Banshi Sabu is not here actually. Yeah. So I just wanted to make one comment on the Dr. Jumani. Thank you for your excellent talk. Just one observation that when we in a diabetic who is complaining of erectile dysfunction and who also has associated hypogonadism, which may be a part of diabetes itself, but I think one should always be very, very careful that we are not missing something, that the low testosterone level is not a part of other anterior pituitary hormone deficiency. So as you mentioned, the evaluation of the
We
taking
should
a
do
good
total and
history
free
for
testosterone, FSH, LH.
symptoms,
We have to do
yeah,
all these tests and
and
then
even a
only start.
prolactin, yes, yes,
Yes,
exactly. So that
because
I just
hypogonadism is not only just a clinical but biochemical evidence has to be there, and
exactly, and it
that has
may
to be taken into consideration. And he should not have any complications of testosterone therapy. He should not be having enlarged prostate or raised PSA. All these things have to be taken care of when you treat hypogonadism. And it is better to partner with an endocrinologist when you treat patients of hypogonadism with diabetes or sexual dysfunctions. And to initiate testosterone therapy, we always need to take an endocrinologist's help. This is very much required.
Can I join in here with a comment if I'm allowed?
Yes, sir. Yes, sir. Dr. Mukherjee.
Dr. Jivani, fantastic talk as ever. Maza aa
Thank
gaya.
you, sir.
Now, I cannot stop commenting on testosterone in type 2 diabetes. We just did a consensus statement that the IDEA group, we published it. We are very skeptical about testosterone use in type 2 DM. Be careful. I saw your presentation. See, I will just take 30 seconds. I mean, you can classify hypogonadism in diabetes as organic hypogonadism, where there is no issues whatsoever. It could be primary, secondary. All the data which comes from improvement of Dandona's data, etc., comes with people with obvious established hypogonadism. If you have something called functional hypogonadism,
Yes.
where there is no organic issues, this is a very dodgy area. It's a very slippery area. So what we suggested was you should only be using testosterone if your value, the value cutoff is always a fight between various organizations, 6, 7, or 8 nanomoles per liter. Multiply that by 30, you get your nanograms per ml or micrograms per dl. And you have primary symptoms, which you rightly said, but the sexual symptoms.
So it is a clinical syndrome, which is clinical and biochemical, and he gave testosterone for 23 months. 23 months, and he didn't find any patient going into complications of CA prostate or any other thing. And he found insulin resistance to be improved. He found hypogonadism, his symptoms of sexual dysfunctions which had improved. They started getting libido, they started getting morning erections. So that
I totally agree with you, provided you choose your patient correctly. Somebody with established organic hypogonadism,
yes,
or
that is
functional
a must.
functional
Agreed.
hypogonadism with a testosterone value below a cutoff 230, with, as you rightly said, the sexual symptoms, which are the primary functional symptoms.
And what we have seen even in women, when we give low dose of testosterone, even in diabetic women, we have found they increased in their desire. This is an observation. I don't know how, but it is seen that they improve. We give them androgels, to apply on the shoulders. We don't inject them with cystanon or anything. Just application of androgen gel have improved their desire. So this is what is the common complaint of every diabetic woman, that they have low desire and they are depressed. So when we give them this, they have shown improvement. So testosterone definitely has some role to play. It is a libido hormone. It is a double-edged sword, but it is useful also in especially in improving the sexual dysfunction if given with cautions. Yes, to young people we should not give for sure, because we may give them azoospermia. But today we see so many young guys going to the gym for making muscles and all. They are taking a lot of testosterone and they have azoospermia. Look at Salman Khan, look at Farhan Akhtar. Their counts is zero. They're not marrying because of it. They absolute zero count. They've been pumping in so many testosterone right from ages. तो कहाँ से उसका testis तो है ही नहीं. It's invisible thought.
I think we should not go into such controversies here. So I
have
think
seen him. That's what. But just to highlight, we should counsel a younger generation not to take, supplements or hormones which the gym instructors motivate them to take to make money.
exactly.
This is one. And second thing, finasteride. Finasteride also, these young people are taking like anything. Most of the dermatologists don't agree to it that they get sexual dysfunction. It is known. And the reversal is not there for 16 years. Once they get erectile dysfunction, for 16 years, they have studies show that till 16 years, they are not getting potency. And young boys, what will they do in their life when they get married if they are impotent at that younger age just because of getting hair?
Gujumani, I have one question. Amongst the fills, sildenafil, tadalafil, which fill is your favorite?
Anything which fills is good.
So which one out
But
of the
according to me, the best is avanafil. Why? Because the onset of action is 15 minutes. You see, you don't have to wait for 2 hours like sildenafil, tadalafil, 1.5 hours, and all other drugs take a little longer time for the onset of action. And you got to take it before meals, etc. Here you can take it anytime. In 15 minutes, it start acting, and it is washed out from your body in 5 hours. And there is less visual side effects and less myalgia, which is common with the vasodilatory effect of all the PD5 inhibitors. You either get headache or backache or anything, but with avanafil, this is not. And there have been now studies going on, Dr. Mukherjee, that PD5 inhibitors can be given to everyone, even if he does not have diabetes, because of the potential therapeutic effects what it's showing. It is improving endothelium by producing vasodilatation, but it has to be coupled with lifestyle modification and reducing all the modifiable risk factors which we are having today.
Dr. Jomani, one more question. What's your take about the 6 hormone binding globulins level, SHBG levels?
See, SHBG levels rise as we age. When they rise, we know that testosterone is 60% bound with globulin SHBG and 38% with albumin, and 2% is free. It is this 2% and the albumin bound which is the bioavailable form. So whenever SHBG increases, the free testosterone reduces, and the symptoms of free testosterone are low desire and low libido and less erections. So we need to understand, whenever SHBG rises, these patients will all get low libido. So we should do something with which the SHBG should become low or remain as much as it is. This is what I might take on it.
How we can decrease the SHBG level?
You take a lot of, with lifestyle modification, you don't age. You may increase the number of your date of birth. Your age may increase, but
true.
you don't biologically age. And fenugreek, the importance is that it has got a molecular structure exactly like testosterone. When you take this, it displaces the globulin bound testosterone and makes free testosterone more available. So when there is more free testosterone available, he definitely feels good. So nothing wrong in giving fenugreek in a saponized form. What is wrong in it? It's a natural food. I call it metabolic medical food. What is wrong in that? Take it. We take methi, don't we? Fenugreek is nothing but methi, and in diabetics it is proven. There have been so many studies that fenugreek is useful in controlling. Fenugreek, bitter gourd, very useful. Kala jamun is very, very useful.
Okay, I think.
And second thing, we are not harming our patients by giving it. We are not harming him. If we give them testosterone, we may harm him. But if we are giving him something which is natural, you're not harming him. You will not feel bad about it. Suppose if something goes wrong, if you have given testosterone to him, he may get a heart failure or he may develop prostate cancer. You will not forgive yourself that you gave him. So that is also a point. So if you give him fenugreek, nothing wrong in it. It's not going to give him all the complications of testosterone.
Thank you, Dr. Jumani, and thanks to all the speakers. Yeah, thank you.
Thank you very much, ma'am.
Thank you. Thank you.
So thank you all.